Now I'd like to introduce Dr. William Futch from Novant Health Gastroenterology, Brunswick. Thanks so much for being here today.
Well, thank you for having me.
Great. Well, I want to start this interview the way I start most of mine, and that's learning more about you. So tell me a little bit about your background and your education.
Well, I was born in Charlotte, North Carolina, and my parents soon after moved to Virginia and was raised in Virginia and did all my school training and graduate school, medical school, and my fellowship training in Virginia before I came home to North Carolina.
So you didn't go too far. You just went to Virginia.
Just up the road. My parents used to tell me that they taught them the 3 R's, reading, writing, and the road to Richmond, and now I'm back home.
Sometimes I ask folks that question, and they've been in like 10 different cities, and they've been all over, you know, with their training and what have you. So I'm curious, what drew you to gastroenterology?
Well, when I was in graduate school, I did a lot of research in immunology and got very interested in inflammatory bowel disease when I was doing my research in a PhD program, and later went in to do my GI fellowship and came back to Medical College of Virginia where I had been working on my graduate degree, and so kind of got pulled into gastroenterology that way.
Yeah, that's interesting. I know most people have a special interest or a focus in their specialty. Do you have one?
Well, I did advanced therapeutic endoscopy training, so my hepatobiliary disease is kind of, and liver disease ended up being my specialty, but you know, I really enjoy all aspects of gastroenterology. It's just a great field to be in.
Yeah, and it causes, so many people have tummy problems, and so we're always happy that you're there, and so I understand what you say when you say it's interesting, because it's just, there's a lot going on there. So when patients come to your office, what are some of the most common ailments or their common problems that they talk about?
People, abdominal pain, diarrhea, nausea, heartburn, rectal bleeding, just about anything from your stomach down to the tail end of the gastrointestinal tract, if you want to refer to it that way.
Yeah, this is kind of a sensitive topic. Do you find that folks are hesitant to talk about some of these things?
I think that's one of the big problems when sometimes we see a delay in people seeking care, is because it's kind of personal and it's not bridge conversation, it's not church conversation, but when people actually get out and start talking about something like colonoscopy, they realize that half the people they talk to about it have already done it, but it's not something that people go out and say, oh yeah, I had my colonoscopy yesterday.
Yeah, I think that might be why some people put it off for so long, because they just don't want to talk about it. And you hear stories about how awful it is, and it's not. I've had one, and it's a piece of cake.
Yeah, and people not being open and discussing it, I think people who haven't gone through it, it kind of lets them, their anxiety and their thoughts in their mind, what it might be like, kind of prevents them sometimes from seeking the help they need.
I think so too. It's just one of those things you don't want to talk about. So,
well, we're here to talk about
we're here to talk about it today, right?
Make
and now they're going to feel better,
right.
And they're going to go out there and make their appointment for colonoscopy. I've had several, and I think it's the best thing you can do for yourself.
One of them
takes care of you. For sure. I know you do a procedure called ERCP. I have no idea what that stands for, but I know that you have, and there's certain people who need that. Not everyone needs that. So tell me what that is and how that happens.
It stands for endoscopic retrograde cholangiopancreatography.
Wow, that is a mouthful.
Yeah, that's why everybody says ERCP, but the most common use of that procedure is for people who have gallstones, and one of the stones may come out of the gallbladder and become lodged in the bile duct, which drains the liver, and they'll develop acute abdominal pain, maybe turn yellow or jaundiced. Sometimes it'll cause pancreatitis. And sometimes when people have acute cholecystitis and have to have their gallbladder out and they have a stone in that duct, they may require an ERCP prior to getting their gallbladder out. So,
I see.
So it's not a procedure everybody needs like a colonoscopy, but it's one that is very necessary in the right setting.
Is it a lengthy procedure?
No more so than a colonoscopy
Oh,
usually,
okay.
unless there's complicating factors.
I know that you're interested in liver disease. Talk to me a little bit about that. How can you help those patients with liver disease?
Well, I mean, a lot of people with liver disease present the same, but there's multiple causes.
I see.
You know, one of the most common causes we're seeing now in the United States is something called fatty liver disease or NASH syndrome, non-alcoholic steatohepatitis, which is caused predominantly by being overweight, and it's very common in type 2 diabetics. But it can end up over time resulting in cirrhosis of the liver just as much as alcohol or hepatitis can, so viral hepatitis. So, you know, it's probably becoming the number 1 or 2 cause of
Really?
cirrhosis in the United States now.
Really? And so you do treat that type of liver disease, correct?
Right, we take care of that. People with hepatitis B, hepatitis C, we treat with antiviral medications now. A few years back when I first got into gastroenterology, there weren't really many good cures for hepatitis C. So now it's almost a 100% curable disease.
Really?
97% of people we treat now will get rid of it. So it's very, very rewarding to be able
Yeah, I'm
to
sure.
cure people now for it. And you know, obviously the thing people think about when they think about liver disease, alcohol.
Right, that's the first thing you
That's
think
one of
of.
the more challenging things to treat because you got to convince patients that they also need to be a real active participant in curing
In their
that
care,
and help
yeah.
them get ready. So,
Yeah, that's true.
so.
Well, we're going to talk a little bit about that dreaded thing, the colonoscopy now. I know there's a certain age, and I think there's been some change to that age here recently. So let's talk a little bit about that. What is the latest guidance for
Well,
that?
the new recommendations are that for all comers, we should start doing screening colonoscopies at age 45.
That's with no problems. Just once you hit 45, you need to have a colonoscopy.
By screening colonoscopy, we're looking for people have normal bowel habits, no blood in their stool, they're feeling great and they're healthy. And the idea of that is to do early intervention and keep them that way. For patients that have family history of colon cancer, we're recommending they get their first colonoscopy around age 40 now. And in the old recommendations, we started that at age 50. So.
Yeah, and they really don't take very long, and the prep is not that bad anymore. I know
No.
early on it was probably not the most comfortable, but they've made improvements.
In the early days, it was you may have heard some nightmare stories about the prep, and people weren't able to drink it. It was a gallon of some horrible salt water, and I used to tell people it tasted like river water. But the volume is less now, and we've managed to make it taste a lot better.
Yeah, it comes in flavors.
Yeah, the down. I mean, it's still.
It's not great,
It's
but
still.
it's
You need to get a DVD and be able to pause it because you're going to go back and forth to the bathroom for the evening. But
that's for sure.
But you don't want to bowel prep on the Super Bowl. So.
No,
But,
absolutely not. And they don't take very long. They take
A normal colonoscopy takes maybe 20, 30 minutes, and then a little bit of recovery time from the anesthesia, and you go home and eat breakfast.
yeah,
And
and
so,
they're not painful, and you don't remember anything. That's the best part.
Yeah,
you
the-
remember nothing.
the anesthesia has improved over the years too, and patients almost everybody. I tell them all the time, you're going to wake up with a big smile on your face. And
That's right, and you're going to be hungry.
And I'm, and patients always smiling when I walk back in the room. And then people getting it for the first time are just so relieved and relaxed, and they just say, I just can't believe how bad I've made this in my mind, and now I realize how easy it is. And the good news about that is that they'll come back and do it another time because they realize it wasn't
Right.
bad.
Yeah, right. I do see an ad on TV where you get it in the mail, the kit, and then you take your own sample and send that back. Are those of value? How do you?
Yeah, the Cologuard is an alternative to colonoscopy for patients at high risk, patients that have had colon polyps before, patients who have family histories of colon cancer and first-degree relatives. I think that they probably should still have colonoscopies.
So that is
and
the
not
goal.
and not a Cologuard. But for that patient that regardless of their risk, just refuses to do a colonoscopy, then the Cologuard's a good test. If the Cologuard's positive, then the next step is a colonoscopy. So, you know, for patients who say they're never going to have a colonoscopy, I'm not sure the benefit of a positive Cologuard if they've got to be willing to say if it is positive, then I'll have a colonoscopy.
Well, that's all great information. It's been a pleasure having you on the show, and I look forward to having you back soon to talk about something as important as colonoscopies.
Great, thank you. I'll be glad to come back.
Thanks for being here.
Enjoyed it.